I find that there are several attendees for the other courses, but there are only a handful of attendees. So education is the right message which should go with this meeting. Okay, I'm going to, a lot of what I'm going to say has already been said, and I'm standing before you and lunch, and Manish has told me to be rather quick. So thanks, Manish, for this invitation, and thanks the IOACON organizers for this very nice invitation. So let's see how resolving the challenges for a musculoskeletal pathologist. As a pathologist, or most pathologists see a lot of skin biopsies, they see a lot of GI biopsies, but the general pathologist does not see a lot of bone biopsies. And understanding normal anatomy and physiology of musculoskeletal tumors in health, injury, and in repair is essential to enable a pathologist to diagnose tumors and differentiate them from tumor-like lesions and from the true sarcomas. And that's because normal tissues can sometimes be mistaken for pathologic processes, and reparative tissues are often mistaken for malignancy. In my own practice, I have seen several times simple calluses, hypertrophic calluses, being mistaken for osteosarcomas, to the extent that I have seen patients who have even received chemotherapy for what was maybe a malaligned fracture. And however much we may say that, in the textbooks that, okay, this is a osteosarcoma and this is a chondrosarcoma, etc., on a slide, things are not so very easy, because distinguishing osteoid, chondroid, and even collagen is not a very easy task. It's not that you put the slide on the microscope and you know what it is. Okay. Well, the importance of the periosteum is something which most pathologists have not recognized. Now, all of us know that the periosteum has a fibrous layer and an inner cambium layer, and the cambium layer has got multipotential stem cells, and the inherent multipotentiality of these periosteal cells needs to be understood by one and all, because whenever there is a fracture, then various kinds of matrices are produced by the periosteum, and these may look like osteosarcomas or like spindle cell sarcomas, and the problem starts from there for pathologists. Now this is an example of a reparative tissue. In fact, this was nothing but an involucrum, and it's so very cellular, and if one puts one nose to the slide, one will be able to see mitotic figures. There is osteoid, there is chondroid, so it has got the right cocktail of constituents to call it a osteosarcoma, because osteosarcoma is a mixture of fibrous tissue, cartilage, etc. But this is nothing but a involucrum. Okay, and these are three examples from my practice, all of which were called osteosarcomas. This is actually a malaligned fracture. This is actually a myositis ossificans, and these are two different patients, and these are examples of hypertrophic periostitis of the small bones of the hands and feet. And all these three lesions, and there are several examples which I have seen in my practice which were mislabeled as osteosarcoma, just because there was very active reparative tissue, and there was no proper discussion between the pathologists. And most of these are referral cases, especially in the place where I practice. We get samples from all over India, and sometimes there is no direct communication which can happen, or there's no access to clinical history, there's no access to x-rays. Okay. So coming back to what has already been said by Dr. Letson, the plain X-ray is the gross picture of the lesion, and this was what was said by none other than James Ewing. And the plain X-ray gives so much information, at least for me as a pathologist, more than what a CT and MRI would do. And the humble plain X-ray is all that a pathologist would want to have, rather than having thick folders of MRI and CT. I do see in my practice, people have very thick folders of CT and MRI, and when I take out all the films, I said, where is the plain X-ray? Oh, it was never done. And this is not at all uncommon. Okay, so normal histology of reparative tissues and the plain X-ray is all I'm asking for, and in addition, history. And this helps me to resolve a lot of my difficult situations. Now, conventionally, the clinician's concept of a good surgical oncopathologist is one who can confidently say what is benign and what is malignant. Even today, this remains one of the most appreciated qualities of a surgical pathologist, and correct diagnosis is indeed very important. But today, the challenge for the surgical pathologist is not merely restricted to giving a diagnosis, because over and above a diagnosis, everybody wants to know what treatment will be given, and will this tumor respond to that treatment. Newer technologies are available today to help us in this direction. And these newer technologies have made a whole lot of difference in the way we pathologists have been practicing, and this is from one of the US handouts, and it's an example with lymphomas. Lymphomas, when they were first diagnosed several years ago, and they were known as lymphosarcomas way back in 1846 when Furco described this. And till the mid-70s, there was just a modest increase in the number of entities which pathologists could recognize by mere morphology. But in the mid-70s came the advent of immunohistochemistry, and subsequently in the 80s we had molecular techniques. And one can appreciate the steep rise in the number of techniques, number of entities which we pathologists could confidently differentiate and diagnose. So a few words on immunohistochemistry. What is immunohistochemistry? It is essentially an antigen-antibody reaction which is done on a histology slide. And so it is actually an extension of routine histology. It is not a very fancy technique, and it's unfortunate that many institutes, even today, especially the teaching institutes, don't have immunohistochemistry because it does come for a price. Every antibody costs a minimum of, say, 200 to 400 rupees, and in a general hospital setting, this is not very easy to achieve. Now, the result of this antigen-antibody reaction is seen as a brown discoloration, and this brown discoloration is to be seen or observed or appreciated in the element of the cell where it is supposed to show the brown color. And this is a typical example of Ewing's sarcoma. It's a malignant round cell tumor, and this is the MYC2 or CD99 stain. So just brown color is not sufficient. I have to see it nicely in the membrane of the cells. And this is another stain, Fly1, and unlike this one which has stained the membrane, the Fly1 has stained the nuclei. So it's not just brown color. The brown color has to be in the correct constituent of the cell. Now, immunohistochemistry does help very much. And for example, all Ewings don't look alike, although it's one diagnosis. So this is a Ewings which has got a lot of rosettes. This is an Ewings which almost looks like an adamantinoma. It's got a very epithelial look. This is an Ewings which looks like a desmoplastic small round cell tumor because it's got a lot of this hyalinized tissue. And this is an Ewings wherein the cells are rather large and they have nucleoli. So none of these look like the run-of-the-mill Ewings sarcoma. Now, sometimes soft tissue sarcomas can occur primarily in the bone. We know that neurofibrosarcomas, leiomyosarcomas, liposarcomas, angiosarcomas, synovial sarcomas can occur in the bone, and this is a synovial sarcoma which did occur in the bone, and what helped me bail out is, apart from the histology, it showed this positivity for this antibody BCL2, and the epithelial element of this biphasic tumor. Synovial sarcomas are biphasic tumors, and the epithelial element was decorated very nicely with this cytokeratin stain, and I could be very confident about my diagnosis. An unusual lesion in the bone, and not that immunohistochemistry was essential, but very often when you make an unusual diagnosis, the surgeon also, are you very sure? Okay, then here is one more thing, I can try and make it more objective if you like. This is now a undifferentiated synovial sarcoma, and it almost looks like an Ewing sarcoma. And it's not that every tissue will have the proteins which we are trying to detect with immunohistochemistry. And in spite of immunohistochemistry, for a pathologist, problems do persist. And in that situation, we need to resort to the newer tools for diagnosis. Dr. Rosenberg did mention about cytogenetics and molecular techniques, and I'm going to allude to them very briefly. The conventional cytogenetics is where you take live tissue, you make a culture, like you make a culture of any say any infective material. So you make a culture, you stimulate the cells to multiply, and then you harvest the cells, and you make these, you make a karyotypic analysis, and this is an Ewing sarcoma, and what it shows is this T1122 translocation. This tumor has a simple translocation, as Dr. Rosenberg mentioned. Part of one chromosome breaks and goes and fixes itself to another chromosome. But conventional cytogenetics is time consuming, it is laborious, we don't have great expertise, and the cultures which are made to grow these cells can get infected, and then you have to throw the whole thing. So we have newer techniques where you don't really need live cells. Okay. So the molecular techniques today are available for all disciplines of laboratory medicine. I mean, we conventionally associated molecular techniques with identity testing, paternity testing, etc., with genetic testing for, say, any of the genetic diseases. Then the field grew very large for infectious diseases. Today we can say whether it's a multi-drug resistant tuberculosis by looking at the genetic testing of the bugs. And of course, the WHO classification insists that for all leukemias and lymphomas, you need to have molecular testing. And solid tumors have been included in the fold relatively recently. And the two techniques which are available for pathologists are PCR and in situ hybridization. These are not new techniques. They have been there for almost 40 years now, and they appeal to pathologists like me because we can now do them on formalin fixed paraffin embedded tissue. Okay, a biopsy has been done and you have already plonked it in formalin, and then we realize there's a level of difficulty. So previously since we were doing conventional cytogenetics, we needed live cells. Now we really don't need live tissues because the methodology has been well standardized for formalin fixed paraffin embedded tissue, and that appeals to surgical pathologists like me because we have a lot of formalin fixed tissue pickled in our archives. Okay. So I'll just speak a little bit about the difference in PCR and in situ hybridization. PCR entails extraction of the DNA from tissue. You make a mishmash of the tissue, you extract the DNA, and you amplify the DNA by putting it in a machine called the thermal cycler, and you assay the amplicon. So the area of interest, which is very small in the DNA, you amplify it several times so that it becomes easily visualized. Okay, just a cartoon to show you what happens. The double-stranded DNA is split into single-stranded, and then one attaches the primers, and if this is the area of interest, and you add what is known as this polymerase, stack polymerase enzyme, and this area of interest then gets extended. So what was a small area which I could not appreciate easily, with the PCR technique, it becomes much more larger, and this is one cycle, and this is repeated several times in the PCR methodology so that the small area gets magnified 1,000-fold, and then I can visualize it. Okay, now as opposed to the standard PCR, okay, the PCR actually needs a lot of gadgetry. It's not as simple as in situ hybridization, and you need thermal cyclers, and you need to run the gel, etc. And this is how the result is in the end. You get bands, and you see whether there is amplification which corresponds to this referral, or this is known as the ladder. Fine. And what is real-time PCR? Just for the sake of completion, real-time PCR is actually like the usual PCR, but in the previous PCR, we saw that the amplification was seen at the end of the test, whereas in real time what happens is with every cycle you can see how much of the amplicon is there, and that is why it is known as real-time PCR, and you get these curves, and with every cycle which is done in the thermal cycler, you know how much amplification has occurred. And real-time PCR also comes at a great cost because you need expensive gadgetry for that. Okay, now what about FISH? FISH can be performed on routinely prepared patient biopsy tissue, and the best thing about FISH is that it preserves the morphological information, meaning thereby if I'm looking at Ewing's and these are the necrotic areas and these are the blood vessels, I'm not making a mishmash of the tissue and extracting the DNA. I'm keeping the histology section as it is, and then I'm subjecting it to in situ hybridization. So the word in situ means that the tissue remains as it is. And we have been doing fish for more than 15 years now, both in the cytogenetic laboratory and also in the last 10 years in our surgical path laboratory. And this is what Dr. Andrew Rosenberg has already shown. These are cells from a Ewing sarcoma, and you see that this is a normal cell, and these are normal copies of the EWS gene. There's a red color and a green color, and where the normal cell does not have the break, and so you see the fusion as a yellow signal. Whereas this is a Ewing sarcoma cell where you have one normal intact allele of the EWS gene, and here the alleles have broken. So this is a EWS break in this patient of Ewing sarcoma, and two other cells which show normal allele and the EWS break. And FISH appeals to us as pathologists because it's really an extension of histology. And we do, we use FISH for rhabdomyosarcomas, we use FISH for synovial sarcomas, and this is a rhabdomyosarcoma wherein we look at the dual color FKHR probe, and it shows that there is not only break, but there's a lot of amplification. So these are the normal alleles, and you see that there is a break, and there are many such signals. So it means break and amplification, and I think this is the way to go today if you want to really investigate these tumors thoroughly. And an example of synovial sarcoma which shows the SSX SYT break. Now, as again what Dr. Andrew Rosenberg mentioned, there are tumors which are complex like osteosarcomas where the mutations are very complex. So there is no single gene signature. In contrast to that, there are tumors which have a balanced translocation, and Ewing's is one of them. Synovial sarcoma is one of them. In rhabdomyosarcomas you see, but there are a whole lot of soft tissue sarcomas wherein this methodology can be used much more easily, and there's a long list which is only growing each day. So molecular testing permits us to give a precise gene-based diagnosis, and they have an edge over immunohistochemistry because in immunohistochemistry you expect the protein to be expressed, and sometimes the genetic abnormality exists but the protein is not expressed, so it's not functional, and so you may do the correct immunohistochemistry but you will not get any result. Whereas in molecular testing you're testing it more at the genetic level, and so the diagnosis is likely to be much more precise, and the methodology is also much more robust as compared to immunohistochemistry. And molecular techniques are not only used for diagnosis, they can also be used for prognosis. For example, Ewing sarcomas with the classical translocation, that is T1122, do much better than Ewing sarcoma which have the aberrant translocations, and there's a whole list of Ewings wherein you don't have the classical. So you may give the correct treatment for Ewings but the patient has not responded. So the answer is not because the diagnosis is wrong, it's because at the genetic level the molecular break was at a different point. Then synovial sarcomas which have the SYT SSX2 have a better prognosis. Similarly, rhabdomyosarcomas which have a PAX3 FKHR have an unfavorable prognosis compared to PAX7 FKHR. So molecular diagnosis is not merely to give a diagnosis which is precise, but it also helps to prognosticate and predict. So now that we have molecular techniques, does it mean that genetic analysis is a replacement for histopathological studies, or these high-tech techniques are the replacement for histological techniques? Not at all. They are a powerful adjunct to complement conventional histopathology diagnosis, and but one thing is there, due to their exquisite sensitivity, they are very useful and superior if one is trying to look for minimal residual disease and also to detect early relapse or to predict and prognosticate. If there is time, I'll just show two cases, but Manish, is up to you, or I can show them after lunch. Just 2-3 minutes. Okay, now this was a 58-year-old physician from the USA who had come to India on a personal visit, and at the airport, while he lifted his back, he felt a sharp pain, excruciating pain in his back. He ignored the dull pain initially, like we all do. We like to wish away our illnesses. And however, the pain persisted, and when he went back to the US, he sought help at a community hospital, and this was what was seen. He had a lesion in the vertebra, and this was sometime on the 26th of April. Then they decided that this lesion was quite sizable, it was symptomatic and needs to be biopsied. So this was what was done. A CT-guided biopsy was done within the next week. Now what happened is the pathologist at the local place was not sure about the diagnosis, and Manish did mention about second opinion, so that's why I think this case is very relevant. A second opinion from another city was sought, and the patient himself, being a physician, also sent some material to, the records of the slide to some pathologists from other states, and the opinions varied. And this was what the biopsy looked like. There was a little bit of bone, and there was this very cellular spindle cell tumor, and this is the higher magnification of the biopsy. It looks very cellular, and we did hear Dr. Andrew Rosenberg say that tumors which are cellular could be malignant. Yes, so that was one of the thought processes, and this tumor also had a wee bit of necrosis, and there was some amount of pleomorphism, and there was this hyaline-like material which looked like osteoid. All this stuff which you see looked like osteoid. There was some pleomorphism, occasional giant cell, and a very cellular lesion. And so the overall features for all the diagnoses which he shopped from various pathologies seemed to indicate that this was an osteosarcoma. And so the patient was advised to undergo neoadjuvant chemotherapy. Now the patient was not willing. I press some long button. Yeah, the patient was not willing, and a curettage was planned to get more material, and the lesion could not be, in view of the location, the lesion could not be completely curated, but this was how the curated material looked like. There was a lot of the cellular tissue, rather pleomorphic, and sorry for that. Yeah, and there was some amount of bone, and some giant cells and what looked like osteoid, and there was mitosis, and one of the pathologists mentioned in his report there is this bone and bone appearance which very often pathologists take as a sign of osteosarcoma. This is normal bone, and there's bone scaffolding on that, and there was necrosis, and it had the correct ingredients, if I may use the word to say that it was an osteosarcoma. But the patient himself, being a physician, didn't want to believe that report, and the patient was put on denosumab, and today, almost 2.5 years after his biopsy, he is doing fine. So I just want to say that bone tumors are not all that easy. You can shop for a diagnosis, but when you have multiple opinions, then again, it doesn't help. And although we do have molecular techniques, and we do have fish, they are useful only in a limited setting. These are not techniques which are available for every lesion. Now this is another physician again who had this lesion on the lower, on the palmar aspect of the foot, which was gradually growing till somebody said, well, it could be malignant, and Manish, you may recognize the patient. And then it was this huge lesion over here, and it was excised. And this is how it looked like. It had this very bone and mixture of whatnot in the center, and this cartilage. And if you look at the periphery, the cartilage looks very alarming. It is very cellular. There was mitosis, and the cells look pleomorphic, hyperchromatic. And any pathologist who wouldn't be experienced would say that, oh, this is a chondrosarcoma. But we knew that this was there for a long time. And on the clinical and the radiological grounds, we were more comfortable calling it something benign. Now, even till today, I don't have a name for this. Maybe Andrew, you can suggest some name from over there. I showed this to Michael Klein, and he said this is a sesamoid bone. Now, I'm not sure whether it fits into that, but the thing is, this is the limitations of morphological observations. Sometimes we can't assign a specific label, but yet we can say, well, this is benign, and it's a mixture of all these cells. And whenever you have a problem like this, you can always send your cases to this gentleman who is here. And I think he would have done better as a Hollywood actor, but I think we are lucky to have him here in the audience. Thank you for your attention.
What was the final diagnosis in that one case?
In the physician, you know, denosumab. Perhaps it's a very expensive drug, I don't know. Yeah. He has responded. He has responded by way of imaging. Actually, it's not a NORAS, because NORAS has a different kind of morphology. In my second talk tomorrow, I'll show a NORAS lesion. Thank you very much. If there are any questions, or maybe after lunch.
Help you to clinch a diagnosis. And Dr. Agarwal told you how to do a proper biopsy, and Dr. Jambekar very illustratively said that what all things you need to see. And I come here with the greetings from the Tata Memorial Center, Mumbai, and more recently now Indian Musculoskeletal Oncology Society, which we just launched a couple of months back. I'm going to talk about staging, and in next 10 minutes in musculoskeletal oncology globally, and then a few recommendations which are given by different guidelines. So what is staging actually? Staging is nothing but it's a cooperation, or it's a wishful thinking between all the people who are treating bone tumors. And what do they intend is that they should have a convergent perspective on musculoskeletal disease, and they should achieve what is very important, that is the correct diagnosis, because your correct diagnosis is going to help you to plan the right management and give ultimate better outcome. So why do we need it? If you look at this graph, which very nicely demonstrate the survival patterns of the patients who have been treated with multimodality therapies, and these have been staggered according to Annie King's surgical staging, and you can see very carefully the tumors which had certain specific stages did much better than the tumors which were having different staging. So this actually helps us to see that we need to identify and diagnose these type of tumors very precisely. We need to see what is the extent of the disease, whether it is locally or systemically into the body, into the other organs. And then depending upon the whole scenario, we need to plan, we need to plot a formulation of our treatment which should be administered in a proper sequence in the right time. So when we are talking about a proper staging system, the system should give us guidelines how to treat. That is very, very important. And the second factor which is very important is that when you are talking to a patient, this staging system should help you to counsel your patient that what is the overall prognosis and what's the treatment I'm going to offer you depending upon this prognosis. So any ideal staging system, it must be relevant and should be practical. It should not be off the hat that we are doing this n number of investigations which do not add anything to the system again. And it has to be reproducible. Like what Doug is doing there in US, sitting there using the same system, I should be able to reproduce here in Tata Memorial, and every one of us should be able to get the same results using the same system. So there are three main parameters when we are trying to assess or stage a tumor. A lot of us think that just doing investigations is just staging, but the first step which we take towards staging is the clinical assessment, which is very, very important. And then radiological evaluation, of course, which helps us to see the extent of the disease depending upon the investigation what we do. And then ultimately, the god of our field, that is the pathologist, should confirm the grading and the tumor which actually we see. So as far as the clinical evaluation goes, I will just brief because all this has been discussed. We see the size, location, the different compartments involved. You always need to see the previous history of the treatment taken, the sites of the scars and the drains, which is very important, and then whether the distal neurovascular deficit And depending upon all these clinical parameters, you will come to a clinical diagnosis whether you will be able to salvage that limb or not. Coming to imaging, imaging gives us three very, very important things which has already been discussed, but just to enumerate: the diagnosis, the local extent of the disease, and the distant spread. So if we want to look first towards the local extent of the disease, the first and the foremost, as we have discussed again in the morning, but I am just repeating it because it's so important, that X-rays taken in two perpendicular planes scanning the full bone is so important, which can give you a lot of information. Further taking on the local staging, you definitely require an MRI, which should also scan your full bone. It should have all the sequences as Dr. Daftari mentioned, and then it should be added with dynamic contrast in today's era to give you more and more information. Now, imaging for the distant spread is a bit more complex. It has a number of variations and options available. We can start off with simple plain radiograph of the chest, which used to be done earlier, and then we went on to have CT scans of the chest for pulmonary metastasis. Now, a non-contrast CT scan, which is thin sliced, that is high resolution, is good enough to give you a good assessment of the pulmonary spread of the disease, and you do not require contrast enhanced CT scans. Bone scans, as we discussed, that tell us about the spread of the disease into the bone. Bone marrow biopsy, as specifically mentioned here, is very relevant for the tumors which arise in the marrow, and the typical examples which we see here is the Ewing sarcoma. Then the role of PET scan and the PET CT, which has been discussed in detail in the morning, and then a few words on whole body MRI. So, as told by Doug, that when you see X-ray, these are the four primary things which you should remember, which can help you to clinch the diagnosis and then can plan your further staging investigations depending upon your initial assessment by X-ray, which includes the type of the lesion, the zone of transition, periosteal reaction, and the matrix. MRI, as I mentioned earlier, that it helps you to tell the exact extent of the involvement of the bone, which may not be very evident on X-rays. As you can see here, that if you see on X-ray, you may see this extraosseous soft tissue as periosteal reaction, but intramedullary extent is quite far up. It will tell you the relationship to the neurovascular bundle, joint involvement, and more importantly, the T3 lesion which throws skip metastasis into the bone. For scanning the chest, CT scan and X-rays, as we discussed, bone scans. A few words on the PET scan. PET scan is presently in the investigatory stages, and globally it is not accepted as the modality for doing the full workup for the patient. A lot of centers do prefer to do PET scan initially, and we have seen a talk today where we mentioned about the role of PET scan in initial assessment and then to see the response to the evaluation. Presently, we are doing at TMS PET scan for Ewing sarcoma and some chondroid lesions. These are the examples where Ewing sarcoma of the proximal tibia have been initially staged with the help of PET scan, and then it is also helpful in the cases of chondroid lesion, which we see, where we can see the dedifferentiated areas, which may be very, very difficult to pick up on CT scan or on MRI, which can easily visualize on PET scan, and then you can target your biopsy with the help of these PET scan. Whole body MRI is a very new concept, which was in vogue in 90s. A lot of papers came onto it, and there was n number of papers publishing every now and then in all radiology journals. And then we have the fusion of PET with the MRI, which is also quite latest in this paper published in March 2013. But ultimately, I got to hold of this meta-analysis, which was also published in October 2013, and which says that the role of whole body MRI is still debatable, and you should not be jumping onto it. It adds unnecessary cost, and we should reserve it for maybe as an investigatory tool. As Dr. Agarwal mentioned, that biopsy is the most important step, and how peculiar, how typical the imaging is, you need to confirm your diagnosis with biopsy. And we had some discussion in the morning, and this slide again shows that this should be the right sequence how you should go. After a clinical suspicion, you should go for proper history, clinical examination, imaging, and then ultimately do the biopsy so that we don't miss any link in between and we hit the right target in maximum number of times. So coming to staging systems, we have two broad staging systems. One is the Anneking system, which was adopted by MSTS, and this is as old as me. I was born in 1977, and Professor William Mencken gave this system. He started the system in 1977, and then which was adopted by Musculoskeletal Tumor Society of America. Then later on, in early 1990s, AJCC initially, which did not agree with the system, ultimately went on to adopt this system and modified it, and we'll see how it went on. So Professor Mencken initially categorized the staging system into two parts, for the benign tumors and for the malignant tumors. For the benign tumors, he gave three tumor classifications: latent, active, and aggressive. A lot of examples we have seen in the morning and the day. I will not waste time on that. Then comes the staging system for malignant tumors, which has three main criteria. And these are the tumor grade, local extent of the disease, and distance spread, that is the metastasis. And depending upon that, broadly, we have three main stages: stage 1, 2, and 3. So all low grade are in stage 1, all high grade are in stage 2, and if any sort of metastasis is there, that comes in stage 3. Now, each stage has further divisions of A and B. That depends upon the local extent of the tumor. If the tumor is intracompartmental, it is A, and if it is extracompartmental, it is stage B. Simple staging system, which all of us follow, very reproducible, but has some fallacies. Then came AJCC system of classification, which obviously is meant for mesenchymal tumors, like Anneking system of staging, was started in 1992 first, which did not include lymphomas and myelomas and the marrow disease. See, basically has four main parameters like any other AJCC system, same like bone, which has primary tumor, that is T, lymph node involvement, that is N, then metastasis M, and the tumor grade, that is G. So ultimately T, N, Mg, which are the four components here. So when we talk about tumor, if we have no tumor, then T0, T1, T2, depending upon the size. Here they have further classified, like in Anneking, we had intracompartmental and extracompartmental. Here the tumor size has been decided as 8 centimeter. If it is less than 8, then it is a T1 tumor. And if it is more than 8 centimeter, it's a T2 tumor. So this was the example of T2 tumor, which is more than 8 centimeter. If it has come out of bone that is extracompartmental, it becomes T2, and otherwise T1. If the same bone which harbors the tumor throws a skip, or there is a skip metastasis in the same bone, these lesions are considered as discontinuous tumor or T3 type of tumors, as shown here. And then further classification went on about this M1, which has the distance metastasis. M1A was specifically given for lung, because the patient who has only lung metastasis fare better as compared to the patient who has other bony metastasis or other visceral metastasis, which were included in M1B, like shown here, which includes lymph nodes and other viscerals and bone. So if we look at the full stage grouping, we have stage 1, stage 2, stage 3, and stage 4. So just to simplify it, all low-grade tumors which are localized, that is not spread anywhere else, they are localized, are stage 1. All high-grade tumor which are localized, do not have metastasis, are stage 2. Any lesion which has a skip within the same bone, discontinuous disease, are stage 3. And any sort of metastasis are stage 4, like Anneking stage 3. But this has been further divided into M1A, which has metastasis to the lungs, any nodal metastasis, or metastasis to the other bone and viscerals. So these systems are not foolproof. They have some limitations, like the size of the tumors. If the tumor is larger, if the size is much, much larger, they may have worse prognosis, and that have not been included. Location of metastasis, this has not been included in Anneking staging. Then total metastatic burden. We have classified the tumors like we have metastasis into the lung or to the bone, but the number of metastasis and the magnitude of metastasis has not been still classified, because the patients who have solitary metastasis, their prognosis will be different from the patients who has multiple metastasis. Now, any grade of tumor which has metastasis have been categorized in stage 4, which may not hold true for the tumors which are low grade. If there are some low grade tumors which throw some metastasis, still have better prognosis as compared to the tumor which are high grade. This classification system is not applicable for the tumor which are originating in the marrow and reticular endothelial system, and of course not ideal for the tumors of the skull and spine, because the anatomical barriers are not the same. Last and not the least, these systems do not include the prognosis depending upon the adjuvants used in the treatment. We all know that the patients who respond better to the chemotherapy has fairer survival as compared to the patients who do not, and that has also not been included. And as I said earlier, the first two of the limitations of anything staging have been rectified or corrected completely or partially in AJCC, but there are still more fallacies which are there and maybe need to be addressed. So I just put few slides for the guidelines which tell us about the staging system, NCCN, which for osteosarcoma, the staging system includes plain X-ray, MRI, CT scan of the chest, bone scan or PET scan, and then a few other investigations. This is here is optional. And to mind you again, as we had discussion, that these are guidelines, these are not the rules. These are the guidelines which has been published to the local area, but we have our own different guidelines. For the Ewings, they do local MRI, PET scan, bone marrow biopsy, MRI of the spine. Again, we need to read very carefully that consider MRIs. It's consider means these investigations are still not the rule and are still under investigatory methodology and some other investigations which require. These are the guidelines again from ESMO, which again says that PET and a whole body MRI can be done, but are still under investigatory tool. And once we have all our information, we reach to the exact staging of the tumor, and the staging will help us to plan our management, to know the prognosis, to plan our treatment according to the prognosis, and to counsel our patients accordingly. Thank you.
So thank you, Manish, for inviting me for this talk. I'm going to speak on the principles and planning of limb salvage surgery. Now, honestly, I feel like a coffin maker, because the body is now ready, and I have to just make a coffin size of the body. But I've not been given the funeral rites by Manish, because I don't need to speak on, also this is not working. Oh, it is. Now, planning is, of course, a very, very good thing to do first. And what is good planning? So if you see this picture, now, where is the planning in this picture? Actually, a good planner will know that the car will be cheaper in the long term. So planning is absolutely essential, whatever you're doing. Let's come to limb salvage surgery. Now, into limb salvage surgery, this is, of course, we are just going to repeat what we have spoken of through the morning. So after a planned neoadjuvant chemotherapy, you go for wide surgical excision. Now, the two most important components of this wide surgical excision is that you preserve the function of the limb, at the same time achieve clearance, oncological clearance of the tumor. Of course, there are certain contraindications to this limb salvage surgery. And of course, that excision will be followed by reconstruction, which should be cost effective, it should be tailored to the patient's need, and it should have long-term durability. Now, there are many methods to do that reconstruction. It could be biological, it could be non-biological, it could be mixed biology and non-biological stuff. So, are there any contraindications to limb salvage surgery? This is very important. Well, a high tumor volume, pathological fracture, involvement of major neurovascular bundle, non-responsive tumors to chemotherapy, involvement of more than one anatomy. So I can go on and on and on. But honestly speaking, this man has taught us that everything in life is relative. So there is no absolute contraindication of limb salvage surgery in the present era. Everything is relative. And of course, I learned that from him. Coming to the clinical practice guidelines, the guidelines issued by ESMO, the European Society of Musculoskeletal Oncology, the first and foremost thing it says regarding treatment is accepted standard treatment is either in a reference center or within reference networks able to provide access to the full spectrum of care. So this is a very important thing which we discussed when Manish was speaking. So all care of musculoskeletal tumors should be in a tertiary referral center where you have facilities to deal with them. The feasibility of limb salvage surgery depends on, of course, it depends on the patient, it depends on the tumor, and finally, it depends on the skills of the surgeon. Actually, when I say skills of the surgeon, I mean the infrastructure which is available in that particular setup. So come to first the patient. Now, this is a child who has got a primary bone tumor here, but he has got mets in the skin. His hemoglobin was 5.5, albumin was 2 gram%. He had a very high TLC, a very high ESR, and a CRP of 16.5. Is he a candidate for limb salvage surgery? Honestly speaking, no, because his general condition doesn't permit that to. In fact, there was a paper from the Japanese group on the value of C-reactive protein and comorbidity in predicting survival of patients with high-grade soft tissue sarcomas. And I'm pretty sure the Grimer group has proved that in bone sarcomas as well. So the patient's general condition has to be good if you are going to attempt limb salvage surgery by any chance. Another patient, a 40-year-old multiply operated patient of a low-grade osteosarcoma of the femur, all he wants is an amputation. In his lifespan, he has undergone at least 12 different surgeries. So now what he requires is an amputation. That's patient demand. And of course, another most important factor in patient is the local need. So this farmer is different from this farmer, sorry. I'm so sorry, yeah. So this farmer is different from this farmer. Patient expectation is therefore a very important determinant of limb salvage surgery in bone tumors. And this is very, very relevant for developing and resource-challenged countries like ours. So we are not the US, we are not England, and therefore we have to work as per the needs of individual populations. In fact, when you offer, say there's a patient of osteosarcoma and we offer amputation, there are always psychosocial issues that why are you giving amputation in an era of limb salvage surgery? In this paper from the Norman Jaffe group, psychosocial functional outcomes in long-term survival of osteosarcoma was seen and a comparison was made between limb salvage and amputation. They evaluated 57 patients, 33 underwent limb salvage and 24 had amputation, and they concluded that irrespective of either amputation or limb salvage surgery, there was participants with more functional lower limb had better quality of life than those with less functional lower limb, regardless of the type of surgery. So this is a very important consideration. On similar ground, this is a paper on Journal of Surgical Oncology, and it showed 33 long-term survivors they evaluated, 19 with amputation compared to 14 with limb salvage surgery. There were more physical problems in the limb salvage group and equal diminution of quality of life in both the groups. So what I want to prove by these papers is that amputation is not a bad choice if the patient is demanding. It's sounding funny that I'm speaking on limb salvage, but I'm just trying to defend amputation. Another paper, comparison of quality of life after amputation limb salvage. This was a very big series. 2,200 patients appeared in the CORR with high-grade sarcomas. 66 had amputation. 342 had limb salvage. Very big, significant group of limb salvage patients. And there was better satisfaction rate in the amputees as compared to those with limb salvage surgery. All other outcomes are the same in both the groups. In fact, it was a bit funny that amputees had more kids than those with limb salvage surgery. So limb salvage surgery is definitely off the shelf. Another important patient, Ewing sarcoma of the calcaneum. We all know there are very limited reconstruction options for these patients. The patient was convinced to go on amputation, and now he's a survivor doing pretty well. So limb salvage surgery, whenever you are seeing, you have to consider the patient factors. Now, this is a patient who has multiple mets of an osteosarcoma. Now, is the presence of metastasis a contraindication for limb salvage surgery? Well, that's a question you need to answer. And this paper from November 2008 Journal of Surgical Oncology from the Rivoli group, high-grade osteosarcoma of the extremities with lung mets at presentation, and they concluded, this is an important conclusion, they concluded that after neoadjuvant chemotherapy, mets disappeared in 14 patients, and they went on to do surgery for all the whole of the group of 40 patients they had seen with metastasis. So actually, metastasis is not a contraindication, provided it is not widespread mets. So, finally, concluding the patient factors, assessment of patient's general condition is important before any limb salvage has to be attempted. Consideration of patient expectation is very important, and this is an important part of the planning for limb salvage surgery. And in resource-challenged environment like ours, it is essential that limb salvage surgery be offered with cost-effective choices. You respect the patient's financial status and offer him the choices that are available for that particular patient. Then there are, of course, tumor factors. So we in India see such big tumors, that huge tumors which come to us fungating and patient really in pain. So you always, as Ashish told you, always stage the tumor before attempting any limb salvage surgery. How do you stage the tumor? I'll just take you through what he has already spoken of. So you know the local radiological extent by a simple X-ray, MRI, and CT scan. Know the distant radiological extent by a bone scan, CT chest or a chest X-ray, and finally know the histological grade. And of course, this gentleman, N. King, gave us this classification. This is original pictures of N. King. He gave what Ashish has already spoken of: stage 1 low grade, 2 high grade, and 3 metastatic. And of course, A and B are intra and extra compartmental. Now that's an oil painting of N. King. It's not a photograph. And based on this, he developed what are called as N. King margins. We all know them. So if you're going beyond the abnormal bone, it's wide excision. It could be marginal excision, or it could be intralesional excision. So this is a 7-year-old boy, Ewing sarcoma of the left clavicle. That is the CT scan showing the tumor is still contained within the compartment. That was his picture on histopathology, and therefore this was low-grade tumor. This was an N. King grade 1A. As against this patient, 18-year-old osteosarcoma of the upper tibia, that the tumor was going extracompartmental, pretty high grade. And of course, when you open the specimen, you see the tumor was going into the joint through the anti-cruciate ligament. This was N. King grade 2B. So this is important that you know the stage of the tumor before you attempt any limb salvage surgery. Now, the imaging for staging, before you stage, the most important, as he spoke, as Ashish spoke, is to do imaging. Whether you do oncology or you do not do any oncology, it's always better to have an all-round view. Because if you're not going to have an all-round view, you're in for trouble. So this was a 28-year-old boy treated with an intramedullary nail for a fractured shaft of femur. This was the X-ray. Looks pretty good, nicely fixed, but they missed that. They did not take the knee view, and there was actually an osteosarcoma in the knee, something what Manish has shown us had to be removed, and a total femur had to be done. So this is what you do not do when you're trying to just evaluate the patient for limb salvage surgery. Another important tumor factor, that's an osteosarcoma at the lower end of the femur. That's the MRI. Now, MRI did show that there was tumor both in the metaphysis of femur, epiphysis femur, and there was also a lesion in the tibia. So, MRI forms an integral part of staging of malignant bone tumors. And of course, Dr. Gulia had clarified that at Stretch. MRI is very important, something which is very important for pediatric patients for evaluation of the epiphysis. Now, this is the X-ray, looks pretty simple, but the MRI shows that the tumor is actually going up till the physis till you remove the specimen and see that actually the physis was involved by the tumor. So, and of course, after MRI, the next important thing in staging is CT scan. That's an Ewing sarcoma of the femur, pretty much only scalloped borders, external scalloping. When you do a CT scan, you realize there's a bit of destruction here, and of course, the 3D reconstruction helps it further. CT scan is very, very helpful, particularly in lesions involving the pelvis. If I say all the 3S, scapula, sacrum, and sternum, are the ideal locations where you can evaluate them better by a CT scan. Of course, then there is a cost-effective but technically demanding procedure called the angiography. I don't want to go into details of that, but there are times when the MRI will not tell you the exact relationship of the blood vessel, and in these cases, angiography comes helpful. So that's 35-year-old male, chondrosarcoma of the right ileum. That's a classical example where all the modalities, plain X-ray, CT chest, and MRI are used before limb salvage is attempted. So that's a 32-year-old patient with a sclerotic lesion of the left inferior pubic ramus. This was assumed to be an osteochondroma and was excised. The biopsy came back as chondrosarcoma. Another patient, a 22-year-old patient, presented with pain and swelling of the right upper tibia. There you see the lesion. It was assumed to be a giant cell tumor. No biopsy was done, underwent curettage and cementing till the biopsy was available, and that was a giant cell rich osteosarcoma. So the basic rule in limb salvage surgery is never proceed without a biopsy. So never assume in bone tumors. If operating on a bone tumor without a biopsy is a mistake, ladies and gentlemen, not doing the biopsy correctly is a sin. And I cannot explain it better than what Manish has done in the morning. And we see all these kinds of patients at our clinic with different kind of scarring, different kind of wrongly placed biopsy scars, which make life difficult. So in fact, we're coming out with this paper, 8 out of 10 tumors which come to the institute have a wrongly performed biopsy. And there we are, that we need to educate on this aspect. And of course, poorly done biopsy turns simple surgeries into nightmares. So this was in diaphyseal osteosarcoma. We had to do a gastrocnemius flap. Luckily, we got through, and the patient did not throw up the skin at the time of at the time of postoperative chemotherapy. So, while attempting limb salvage surgery, never do a biopsy if you don't know how to do one. And that's a very, very important message that you can take back home. Is tumor volume a predictor of limb salvage surgery? So we always see such big, huge tumors. Is this a predictor of limb salvage surgery? The answer to that is no. Why? This is our study. What we did was, we calculated tumor volume in osteosarcoma and Ewing sarcoma, and we graded them into less than 50, 50 to 200, and more than 200, and we saw what was the local recurrence rate. This was a retrospective study of the last 8 years, and we found, and similarly we did that in Ewing sarcoma, so we compared both Ewing's and osteo, and we found the local recurrence is more common in patients' small tumor volume. This is not something which we expected. In both the sarcomas, it was statistically not significant. So, tumor volume is important per se regarding the practicality of surgery, but statistically it is not significant. And this has been proved off and on by many studies by Picci and Bachi. So that's a 28-year-old fungating GCT, and I agree, fungating GCTs are different tumors, they're not sarcomas, treated with excision and anal translocation. That's a patient, and that's the wire that is holding on to the anal translocation, and patient doing pretty well after everything is out, the skin has healed. This is an important paper, these are not my pictures. So here you see a pre-chemotherapy MRI showing that the vessel is still free. In the post-chemotherapy phase, the neurovascular bundle gets involved, and that's very critically demonstrated in this picture. In this paper, role of surgical margin local recurrence in high-risk extremity osteosarcoma, this was a case-controlled study from Seoul. They found that local recurrence in osteosarcoma was the most prevalent in soft tissues, and they were able to show that it was the perineurovascular fat plane on the preoperative MRI which is a predictor of local recurrence. So yes, tumor volume is important, now it becomes important till the time it involves the perineural vascular tissue. This was an important paper. This was a 28-year-old female with osteosarcoma distal femur. Unfortunately, the patient had little response clinically to chemotherapy and therefore was taken up for for surgery, for limb salvage surgery. MRI demonstrated that still there was some plane between the perivascular tissue, but when we opened it, we found that the blood vessel was going right into the tumor and she had to go in amputation. So, limb salvage should be attempted in tumors with good initial response to chemotherapy. And initial response to chemotherapy is a very important clinical parameter that you can see and decide whether limb salvage surgery is required or can be done or not. But of course, surgical margins are very important. So this is osteosarcoma of the upper tibia in a 12-year-old girl, initially treated with wide excision and prosthesis, and you see a huge amount of local recurrence both in the specimen and in the X-ray. The response to neoadjuvant chemotherapy, and she had a poor response as well. Response to preoperative chemotherapy is the strongest predictive factor determining local recurrence in bone sarcoma. This is an important announcement which has been done in all these studies through 90s by Picci, by Bachi, Grimer, and Lin et al. So this is an important fact that if the neoadjuvant chemotherapy has not worked, probably there's a high chance of local recurrence. And of course, whenever there is a patient who is undergoing neoadjuvant chemotherapy, try to see the response to neoadjuvant chemotherapy. For example, this fracture in osteosarcoma, the fracture is healed under neoadjuvant chemotherapy. Now, there are certain unpredictable tumors. This is an 8-year-old female osteosarcoma distal end of femur, and the tumor was taken out, but we did not do a reconstruction. Why? Go back and you see this was a huge tumor. So this was a huge tumor. The neurovascular bundle was nearly in contact with the tumor. There was a fat plane, very, very kind of meager. So we were not sure whether the patient will have local recurrence or not, and therefore we had to put a spacer instead of putting something more expensive. So that's a cost-effective way of saying we care. So if the patient remains, and this is a practice which we now have to follow in view of the large amount of tumor volumes that come to us, that we have to just put a spacer in the first stage surgery, send the patient for second cycle of chemotherapy or other post-operative cycles of chemotherapy. Patient comes back to us and we do the definitive surgery, definitive fixation. Of course, biological behavior is important. So that's an 11-year-old with a parosteal osteosarcoma of the left femur. Now, parosteal and surface osteosarcomas are the good boys of musculoskeletal oncology. They're usually low-grade tumors. Of course, there is a dedifferentiated variant. The tumor was taken out, step-cut osteotomy, ECRT was done, and the tumor was fixed back, and that's the immediate post-operative X-ray. So there are tumors which behave bad, and there are tumors which behave good, and this should have a bearing on limb salvage surgery, the knowledge of this fact. Of course, whenever the biopsy report comes back to you, you're very happy to see that the resected end of the femur and tibia are free of tumor. So contamination, surgical margins of the tumor are one of the most important and significant predictor of local recurrence. And this has been proved off and on. That's a 16-year-old correctly diagnosed as chondroblastoma. Curettage bone grafting was done. These are not my pictures. And 3 months post-op, the tumor literally explodes out. So what was wrong? Surgical margins were missed. So this very important paper by Pichi tells you that risk factors for local recurrence, there's the single most important risk factor is a contaminated surgical margin. So whenever you're doing a limb salvage surgery, make sure your margins are free of tumor, the resected margins. Frozen is therefore very, very important in these patients. Another paper by Grimer, and that again shows that the local recurrence, the single most important significant factor affecting local recurrence is surgical contamination of the resected margins. So it is essential to have a clear oncological margin whenever you're doing tumor resection for limb salvage surgery. Of course, there are surgeon factors all over the place. Good teamwork can achieve the impossible. So you need to have a good team when you're doing these patients. Team consists of a medical oncologist, a radiotherapist, surgical oncologist, and orthopedic surgeons. So orthopedic surgeons really down the ladder, down that pyramid. But this is important that you build your team, an MDT team which can take care of these patients. Important, it is very easy to find surgeons, but it is difficult to find good ones. And we are always in this mood of pulling and pushing, so orthopedic oncology is not that part of orthopedics. What are the surgical options of salvage? I'm not going to go into those details. So what are the surgical options of salvage? Surgical options can be biological or non-biological. In the biological group, you have no reconstruction, arthrodesis, extraphyseal reconstruction. And in non-biological group, you have endoprosthetic replacement, but then you have a whole array of mobile joint bearing biological actions like osteoarticular allografts, allograft endoprosthetic composites, rotation plasty, and autoclave tumor bone. So the spectrum available for limb salvage surgery has enormously increased over the last 10 years. Our understanding of tumors has increased, implants have become better, chemotherapy has become better, and therefore we can now do much more. These are the common methods that are used, for example, in our series on osteosarcomas. We do prosthetic replacement, but then a big chunk, the green one, is anterior reconstruction and the remaining biological options. We also do a significant amount of arthrodesis. Professor Rastogi is going to speak on that tomorrow evening. So that's an endoprosthetic replacement. The average MSTS score in these patients of the order of 25, 24.6. We had about 54 of these patients. They do pretty well. Now this is to